first one, Ollie, let me just bring it back up again. Very straightforward, and a common one, I think. Hopefully everyone will find this beneficial. It was simply, the question was, could you explain more about bursitis, please?
And more specifically, in the hip.
In the hip, yeah. So we got back to this person and asked them where the problem was, and they told it was in their hip. So bursitis is a really common complaint that we hear of in physio. And I think what we want to do is, first of all, sort of explain what it is, and then sort of how we would manage it. I'll kick this off, Ollie. So the term bursitis is an interesting one, and over the last few years in the world of physio, we've sort of moved away slightly from the diagnosis of bursitis. But when people come in and they have bursitis, generally what they're describing is pain on the outside of their hip. So this patient will come in saying it's very sore to touch the outside of their hip, and any pressure on their hip is painful. So this is the patient that can't lie on the hip. They'll be woken up at night if they lie on that side. This patient will often tell us that they start to get pain if they walk too far, or if they get caught standing in a queue, they'll start to get pain on the outside of the hip. We differentiate it from other types of hip pain because it usually is on the outside.
It's definitely more lateral,
Yep. They don't have actually anything wrong with their hip joint, so this is not the patient with hip arthritis. Their hip joint is usually in good shape. They don't usually have groin or back pain associated with it. Now, it can travel down on the outside of the leg, but very rarely below the knee, so it would just be on the outside of the thigh.
Yeah, and if it does go below the knee, it just goes barely below, kind of on the lateral shin. It doesn't go all the way down to your foot. That's something else.
Yeah, again, we would be looking at sort of a different diagnosis for that. So these true bursitis or lateral hip pains, you know, it will be mainly on the bony part on the outside of the hip, can travel down the leg, and as Ollie said, on the ones that are bad will present as sort of lateral knee pain as well, a little bit, particularly if they've been walking or if they run and they've got lateral hip pain. So this term bursitis, well, really interestingly, some of the studies that looked actually at ultrasound and sonography of the outside of the hip to see what was going on, the bursa was getting blamed, but in a lot of cases it wasn't just the bursa causing the problem. So where this bursitis, where the pain comes from, is on the outside.
Reverse it back. What is a bursa? You're saying bursa, but
okay, let me describe it. Yeah. So on the outside of our hip bone, we have the ball of our hip. Then there's a neck of our femur, and then there's a bony protuberance as the long shaft of the bone starts. We call it a trochanter.
Yeah, normally you can feel it just around kind of where your pocket finishes. You that bony bit, that's not the actual joint, that's the bone on the outside. The actual ball is located right in around, deep in around your groin area. So we're talking about the area around the outside of your pocket.
Yeah. So on that bony part, it's a real big area where different muscles attach. So a lot of your glute muscles, which are the big muscles that move your hip, the deep muscles that rotate your hip, lots of their tendons, so the ends of them, attach into that bony part that Ollie's talking about on the outside of the hip. And then around that greater trochanter, you don't just have one, you have loads of little things called bursas. And a bursa is basically a little fluid-filled pouch. And its purpose is to allow the tendons to glide and slide and move comfortably when we move our hip. So they're filled with something called synovial fluid. So little membrane sacs filled with fluid.
Like little cushions, basically, shock absorbers, kind of in between the tendons.
So what then goes wrong with this bursitis? Well, what these images have shown that it's not just the bursa causing the problem, and in fact we're starting to think now that the bursa is a symptom of a problem that actually is to do with the tendons. So we're now starting to think of this bursitis problem as being more related to the little areas of white tissue where the muscle attaches to the bone, where our glute muscles attach, mainly glute med, glute min, a bit of piriformis, where that little white tendon tissue, in these patients are having problems, those tissues have tiny little tears, and they're actually thinking that that's where a lot of the pain is coming from. And then that is irritating the bursa. So they're finding less and less inflammation within these bursas, and that they're thinking the pain now is more to do with tendon than it is to do with bursa. And also sometimes there's an element of, there's a deep layer of fascia that runs down the outside of the leg called our iliotibial band. And they're finding that part of the iliotibial band can be irritated where it comes from that bony protuberance on the outside of the hip. So I guess what I'm saying here is that we probably think now that bursitis isn't just bursitis, and that it's actually now greater.
It's more of a symptom.
Yeah,
than
it's
anything.
a symptom.
It's a symptom of the overall condition.
Yeah, and we're tending to call it now a sort of greater trochanteric pain syndrome. So that bony part is the trochanter, and then the syndrome part is that it's not just the bursa, that the tendon is involved as well. So that sort of explains what we think is going on.
So what do we do about it?
Well,
what can someone do?
What can we do about it?
What can someone do about it if they have it?
So if somebody has it and they're having pain lying on that side, walking, standing, what happens when you walk or stand is that you contract your glute muscle to keep your pelvis level, and then the tendon pulls on that little bone on the outside, and that causes pain. So the first thing that we would say for those, sorry, we've been in the background, first thing we would say is that try to stop the compressive force on that lateral hip. So if you're getting pain when you lie on that side, the first thing that we would recommend is try to avoid lying on that side, or positions where there's pressure on the outside of the hip.
Okay. Well, you say lying on the opposite side, so you're lying on your good side, but what I also see is that once the knee starts to come past the midline, so if they're lying on their good side, and the top leg and the knee starts to drop down, that can also just pull at the tendons.
That is true.
So the best thing to do there would be to pop a pillow, or even two pillows, in between the knees to keep the knees open as you're lying on your side, and that just offloads that tendon and makes it a bit more comfortable for you to sleep on. Good, so they can offload it.
Offload it, yeah. The second thing that we are now managing these bursitis with, so conservative management, we should say, is what we're talking about here. Conservative management is the forced protocol, which is offloading it. Patients then can get short-term symptom relief from either ice or heat over the bursa. Now, that's not doing anything more than just deadening the pain short-term, but it is an option to try and manage the symptoms. And then in our conservative management, we focus on trying to restructure that tendon, and that involves strengthening exercises of mainly the glutes and the hip rotators. So any of our patients that come in with this greater trochanteric pain syndrome, I try to find an exercise that they can tolerate that exercises their glutes. Would you agree, Ollie?
Absolutely. Keep loading, trying to gradually load the glutes.
Yeah.
Start off nice and easy.
Yeah, I usually start really, really simple, like our clam exercise. If you Google clam, you'll see what I'm talking about. That's a really good one because it works your glutes and your hip rotators, and that tends to be the bit of the tendon that's most irritated with bursitis. Now, some patients can't even start there, and like always, our advice is if you're in any doubt, you get it checked out with your healthcare provider and they'll guide you. But generally, you would start with a simple clam.
If you can tolerate it.
If you can tolerate it, progressing it onto side leg lifts. There's some nice ones that you can do in standing too. And if standing is a problem, often I'll get my patients to just practice standing on one leg, seeing how long they can tolerate that without pain.
On the bad leg.
On the bad leg, and then grade that up to see how they go. And again, that's just a strengthening exercise to load the tendon. So conservative management is really focused about trying to restructure and strengthen up that tendon.
How long would it take to restructure the tendon?
No, so this is the problem. You have to be patient. Like, this does not change overnight. You're really talking about committing to a plan that's probably, you want to see them responding within the 6-week window, but really these patients need to commit to their exercise program for 12 weeks up to 6 months to really get on top of it long term.
When you say responding within 6 weeks,
start to see an improvement.
In symptoms.
Yeah.
Okay.
What do you think?
Absolutely, I completely agree.
Yeah.
It's a long road with this problem.
Yeah.
You can't restructure, reorganize tendons and muscles overnight, but if you stick with it, all the studies show that there's really, really good evidence to say that strengthening up that hip can help recorrect that imbalance and offload it to make it, well, not offload it, but to reload it properly. So
Yeah.
Just
to be clear on that, we, like, in terms of contact with physio, this is one of those things. It's not a weekly event either. With these patients that come in, if they're very irritable at the start, we might see them a few times to begin with to make sure that their exercise is comfortable, but then we'll send them off with their strengthening program to work on it for 3 to 4 weeks, then come back to us, and then we'll progress it and we push them on again. So really finding the exercises that you can tolerate are key. If it doesn't work, like what? Because I know loads of patients that have had injections for their bursitis. like, what do we feel about having injections for it?
So yeah, there's good evidence to show. We've had a few questions in. We'll go through it in a second. So there's good evidence to show that the injections can really help and can really work. Normally they can do up to about 3 injections. They don't like doing a whole lot more than 3 because there's risks obviously involved with the injection. It can weaken the actual overall structure of the tendon, which is not good for it, but it can really help to settle that acute inflammation, acute pain down, to allow you to engage in your conservative rehab. I have had some patients that have had the injections and didn't engage in any conservative management, and then what happened was the pain initially settled for a few weeks, and then after a period of time, once the injection wore off, pain came straight back again. So what we did was we started them off in their graded exercise and then sent them back for the injection, for another injection, and when they came back then we kept going with their exercises, and they got really good outcomes. But there's also another thing to point out, is that it's not just the hip that sometimes causes the pain. Sometimes we have to look above or below the joint, so sometimes we look all the way down to the foot, because sometimes the feet, if you've got quite flat feet and you're collapsing in when you walk, that can also cause load up on the hip, and equally the hip can sometimes cause people to get things like plantar fasciitis that we spoke about last week and things. So that's probably one of the...
I just want to say about the injections that it definitely, from a research viewpoint, like, the injections do give short-term relief, but when you compare, shockwave therapy is another thing that people have done with bursitis, but in the studies when you compare injections, shockwave therapy and conservative management of exercise, at 6 weeks the injections look like they're best, but actually long term, over a 15-month period, it's the people that engage with the conservative management that improve long term. And another point about the injections is that the guided ones work better, and if somebody isn't getting any relief, if they're doing their conservative management and we're getting nowhere and we're looking for something else to try and help us, we would try and get a guided injection where we can. That's where they're using imaging to see where the actual steroid is going into.
But as a rule of thumb, they would normally do the first one or second one unguided, so they would just stick it in and see how it works.
And it is worth a shot.
It is, literally.
Literally worth a shot.
So there was another question as well that we got last week then, was...
Well, hopefully that clears up anything about bursitis. Which we call greater trochanteric pain syndrome, and it is worth googling that term because you can get good tips and advice from that.